Good morning, everyone. We're recording from the second annual Association of Pulmonary Advanced Practice Providers National Conference in Nashville, Tennessee. My name's Vincent DeRienzo. I'm a senior physician assistant in the medical ICU at the University of Rochester Medical Center. I'm also a co-director for our Critical Care APP Fellowship. And I'm joined today by my two guests who will be presenting this talk tomorrow at the conference. If you guys want to introduce yourselves.
Hi, I'm Ambera Dedic. I'm a nurse practitioner. I specialize in endocrinology, and I feel very grateful to be here joining the pulmonary APPs as we navigate the interesting intersect of steroid use in pulmonary and how it influences and affects the endocrine system. I practice in the Bay Area at Stanford Health, and again, just really happy to be here for this year's APAPP.
Great. And I'm Greg McClelland. I'm a physician assistant at Dell Children's. So I work in pediatric pulmonology. I've been doing that for about 13 years. I serendipitously talked to Corinne just around the time APAPP was starting quite a number of years ago. So I was able to be on the board early on, and I'm happy to be on the pediatric subcommittee at this time.
Great. Awesome. Well, thanks, guys. And I guess we'll put together a little talk here about what we're going to present tomorrow. So we were tasked with putting together a talk about the use of steroids in various patient populations across the lifespan. And coming from the pediatric side, I think we'll start our story there. So, Greg, what can you tell us about steroid use in the pediatric pulmonary population?
Yeah, obviously we use it a lot. The biggest thing is asthma, since that's such a prevalent condition, as you all know. One of the things for our talk tomorrow, I just kind of want to emphasize really two main things. Since we're using it frequently, obviously the thing that we're trying to do and we try to convey to our patients is how we're trying to use the inhaled steroids to minimize the systemic. I always talk through pathophysiology with patients and talk about sprinkling a little bit of steroid in on a regular basis so that we can keep that inflammation down and avoid the oral steroids and the side effects that come along with that. Of course, avoiding the ERs in hospitals and things as well. I'll start with that.
Great. Awesome. Going to the adult side, things have changed in the past couple of years with some new societal guidelines that have come out. And, I think the biggest thing that we're seeing in terms of steroid use is that the indications have gone up. And with good data from great randomized control trials, huge patient populations, and with good meta-analyses. But with that, we're seeing the expanded use in folks with sepsis. So anybody on a vasopressor, doesn't matter what dose, are now recommended to get steroids. Folks with ARDS and all of its phenotypes, regardless of severity, are recommended to get steroids now. And then most recently, our severe community-acquired pneumonia folks, bacterial community-acquired pneumonia, I should say, have the recommendation now from our societal guidelines to get steroids, which is a big update from the last IDSA guidelines. However, I would be remiss to not talk about the recently published REMAP-CAP trial, which is a trial design and Bayesian analysis that, for the life of me, I can't figure out. And there's a lot of other folks, I think, that are in the same kind of boat that kind of argue against the use of steroids in that severe bacterial community-acquired pneumonia group. So I think, as things often do on the critical care and adult inpatient side, that'll swing back and forth a few times. But as we've talked about, our patient population's getting more and more steroids and trying to steroid spare. I think Ambera can hopefully shed some light on why we should be striving for some of those goals.
Yeah, it feels like a catch-22, as we've talked a lot about as we've gotten together and worked our way through our own presentation for tomorrow. There's such an importance in using steroids, right? There's so many indications. In endo, we use them as well for some of our own endocrine-related conditions. But at the same time, there's this thought of stewardship. And how do we sparingly use steroids? When are they really necessary? Do we follow a guideline or do we look at the patient? Do we use oral versus inhale, to your point, Greg, earlier? And I think when we take all of that into consideration and then consider further a little bit more into beyond the pulmonary use of the steroids, how is that affecting someone when it comes to their endocrine glands? And what does that mean? And do we use short-term versus long-term? Because that, of course, as we know, will contribute to a different outcome too. I think from the endocrine standpoint, my hope with our presentation tomorrow is to build that partnership between POLM, primary care, endo, whoever is managing endocrine patients, specifically people with diabetes, whether it's type 1, type 2, pre-diabetes, insulin dependent or not, having those channels open amongst all of us to really coordinate together. Because if someone does need steroids from a POLM perspective, how do we make sure that they're also being taken care of with the sort of, I don't want to use the word fallout, but for lack of a better word, the side effects and the implications it will have on their endocrine system. And I don't think the ownership of managing those side effects should be on my POLM colleagues, but we need to bridge that gap and communicate and talk to each other about this patient's receiving steroids. And I noticed, they have diabetes, FYI, and we'll gladly take that on. But I think opening up the channels is hopefully the message we'll send tomorrow during the rest of the conference, which is exciting.
Yeah, absolutely. I mean, talk about collaboration. This group has fostered a lot of that over the past couple of years, so it'll be a good thing. Greg, I was wondering, in your practice, is there anything that you do specifically or that your group does to try to spare some of that systemic corticosteroid use?
So, yes, for sure. I mean, we definitely, talk about with asthma, stepping up and stepping down in therapy, right? And that's one of my cases tomorrow is really going to highlight the need to step down. We had a patient that just fell out of the way of our practice. We didn't see him for about a year and a half. He was admitted for surgery. And luckily, because he had hemophilia, he was admitted so they could watch him after that. And he had an adrenal crisis while he was inpatient. So it was fortunate for them because people could intervene right away. But the reason I bring that case up is because we didn't see him for about a year and a half. He was doing well, and his PCP just kept him on BSNAD 160 for Motorol. And just being on that for 3 or so years and just eating oral steroids once leading up to the procedure, not even right before the procedure, he had that crisis. So granted, I had the perspective of seeing him a bit after that crisis and saying, hey, we haven't seen it in a while. How's your asthma been? He had been doing well. But I think the PCP was like, they're busy with a lot of things. He was doing well with that. I don't know if they just didn't think about it much or they're just like, oh, let's not rock the boat. And they just kept him on that same strength steroid, which he easily could have stepped down, which is, of course, what needed to happen. And he would have been at less risk. So yeah, that's the big thing is just stepping down. We're big fans of even giving holidays during the summer months for the more mild patients, just to give them a break altogether as well.
Yeah, I think it's tough for us on the inpatient side of things because the indications that we have and the data that we have shows us that we get a mortality benefit. So to have complications, you got to be around to have complications. And so I think it's really challenging. And when I work with my pulmonologist colleagues that do their service time on the unit, I think they struggle because they see the efforts that they're doing isn't on the outpatient side of things to try to spare some steroid use. And here you come to the ICU and you get the mirepoix of pulmonary medicine of, antibiotics, diuresis, and steroids. And, almost everyone that's coming to the unit is getting that. So I appreciate you guys giving us some wiggle room with these folks to spare them some lifetime steroid exposure on the outpatient side of things. Because I think at least where the data is right now and where the recommendations are right now, it's really challenging from the inpatient side to justify the sparing. Even though, the disease state models for these things is not great. We're talking about really heterogeneous groups, ARDS, sepsis, there's just so much that goes into that and who's actually benefiting from that. And there's been a few interesting retrospective analyses of some of the big steroid study trials that have looked at subsets, and maybe it really is just the pneumonia group that benefits from this. So maybe in the future we'll get some more patient-specific and some directed therapies. But right now it's tough. It's tough for us.
Are you seeing changes so far where when you're implementing these new guidelines, using more steroids, then are your diabetics and it's harder to control? Obviously it would be. How is it playing out in your day-to-day life?
Yeah, there is a very big impact on the patient side of things, not just while they're inpatient, but in our catchment area, we have a lot of socioeconomic disadvantaged patients. So a lot of challenges if you're making huge changes to their insulin regimen, medical literacy is really low. It took a long time to get people on a regimen that works for them. And they may not be the standard, textbook regimen, but it's what works for that patient because of resources and education, all that kind of stuff. So when they come into the hospital and we have to get these folks ready for discharge, it's a real challenge. Like we're really, really struggling to get these folks to say, hey, like, I know that you've done it this way for 10 years and it took 10 years to get you to that point. But because of this acute illness and because of the changes we did here, we've had to make these changes. And there's a lot of challenges with that. I'm very fortunate to be at a center that has a lot of ancillary support with like diabetic educators, and our endocrinology colleagues on the inpatient side are fantastic and able to really follow up with those folks and help them navigate that. But it takes a lot of resources. And if I wasn't in the setting that I'm in, I can't imagine trying to get these folks back into the community and keeping them there and not coming back into the hospital. So we see it. We see it all the time. There's a lot of use of insulin infusions on the units because it's just, especially at the doses that we're using for the critically ill, it's so challenging.
I was going to ask, that was my question, is how do you do the discharge planning? But it sounds like your organization has that pretty well established. But again, highlighting the importance of collaboration and really going back to thinking about steroids being prescribed, patients with known history of glucose disruption at whatever level, and keeping in mind that these two they kind of go hand in hand because we know that the steroids will affect their blood sugar, and who do we call on and get involved in that care. So I love that that's set up at your organization. What about for you? What does that look like as far as using steroids, Greg, and partnering with other staff or other clinics or teams for where you're working to manage endocrine-related impact?
Yeah, it's a good question. It's been a bit of a challenge, I would say, at our institution. Fortunately, we don't have a lot of patients that have the comorbidities of asthma and diabetes, but there are some. And so we tend to, I was talking about stopping altogether in the summers earlier. Probably not going to do that in a diabetic because that whole risk benefits. We just don't want to need those oral, or systemic steroids at all if we can avoid it. If there ever is a need, we certainly can reach out to endocrine. But yeah, I would love to see that built up even a little bit more at our institution.
Yeah, because then the catch-22 is, can those inhalers, like that patient you mentioned earlier, what about keeping them on them? And what about adrenal? And then it's always like, there's always something, kind of embedded within steroid therapy and the endocrine relation there. So it kind of brings that up too. Gosh, it's a lot to balance.
So I looked in the literature and I did reach out to a couple of the endocrine colleagues about like, hey, so when should we be screening? And I was glad, honestly, that they got back to me. But I didn't find, and they didn't have for me, I'm like, I figured they're AAP, Endocrine Society, there's going to be very clear guidelines on when to screen. And I don't think there are. Like, what advice do you have as far as like when you should be screening people for, you mentioned like adrenal suppression?
I think it's kind of a hard question, but I would say time, like length of time on treatment, would be a possible indicator depending on the dose of their steroids and the length of time. So I don't know how it would fit in the pediatric space just because that's a little out of my wheelhouse. But if I was prescribing steroids in the adult space, I think, my mark would be, 3 months, 6 months, thinking into, should we start kind of spot checking what your cortisol level looks like? Definitely if they're symptomatic, of course, really looking into it. But I think time, and I wish I had a better answer too, but I think time would be a big factor.
Right. Yeah, I feel like there's just a gestalt that probably to some degree we need to even develop more. Because I think it can a little bit slide into white noise because we're so used to I'm using the inhaled steroids to avoid the systemic steroids. But just like that case of the 6-year-old with the hemophilia and asthma, like if you're on enough inhaled steroids, you still can run into trouble. So it's kind of, there's always that art and science of medicine. And it seems like this is a little bit more on the art side.
Well, I think we're getting close to our end here. So any kind of closing thoughts or anything you guys want to send out to the folks that are going to be listening to the podcast here?
Again, thank you for having an endocrine person join. We hope that you'll enjoy our talk, and I'm really excited to present tomorrow with both of you.
Yeah, I'm glad to be a part of it. I'll say it's fun being here. I went to the conference last year in Vegas, and at that point, there was only one session on pediatrics. I happened to be doing half of it, and so but I still learned a lot, just kind of taking in, because there's some similarities. Kids aren't just little adults, but there's some similarities and things you can learn. It's good to get a feel for what's going on. But for people who are hearing this and haven't been to conference yet, I would say, come if there's any way you can swing it, because honestly, people are so enjoyable here. Like they're very welcoming and warm. And so it's just a great opportunity to just bounce around with some of your colleagues who you may not know, but you could meet some new friends.
Yeah. Greg, similarly, critical care was a little underrepresented last year, and it's expanded this year. And I've learned so much from the collaborative efforts and, seeing folks that I wouldn't normally, see professionally. So this is, I hear you. I couldn't encourage folks more to come out next year. And well, thank you guys so much. This has been a lot of fun. I'm looking forward to tomorrow morning, and we'll sign off there.